بسم الله.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Amr Ismail. I'm an ER physician. I am the section head of the ultrasound section at the Saudi Society of Emergency Medicine. I am thrilled actually to host two great colleagues, Dr. Hussain Alhashem, who is an emergency medicine consultant at the International Medical Center, and he's trained in fellowship, ultrasound fellowship, and Dr. Amr Ajlan, who is consultant of radiology and an associate professor of radiology at King Abdulaziz University. So we are of course talking about the hot topic of the hour, which is COVID-19, and specifically we'll be talking about the radiological studies in a patient with suspected COVID-19. So we are going to be talking about POCUS. Dr. Hussain Alhashem will I'll go over the POCUS application of lung studies in the emergency department, and then Dr. Hussain will give us his input on the POCUS application in COVID-19 patients specifically, and then we'll shift gear and have Dr. Amr Ajlan to talk about the chest X-ray and CT findings. So I personally don't have financial disclosure. I just want to point out that we always need to go back to our Ministry of Health for guidance, wiqaya, to get all the guidelines, and then also follow our local institute regarding how to take care of our patients. Of course, we also want to get the information which is collaborated between the Ministry of Health and the CDC and WHO. So let's jump right in. So we have the clinical presentation of COVID-19 patient. As you can see, it has a lot of things that can be presenting. So we're talking about a patient who's gonna be coming with cough, fever, fatigue, sputum production, shortness of breath, sore throat, and headache ranging between 14% all the way to 68%. And this is according to one of the articles that was published early in the in February of this year in the New England Journal of Medicine. And then the examination findings are non-specific, and also you can see a little bit of throat congestion in less than 2%, throat tonsillar swelling, and then rash less than 0.5%. So the differential diagnosis can be a bit broad. So you can see these clinical presentation with seasonal flu, common cold, non-specific viral illnesses, and then the sepsis of non-COVID-19 origin. We also are going to be sharing a bit of presentation of congestive heart failure and or pulmonary edema with this clinical presentation. So the issue with the COVID-19 is that the case definition can be really vague and really broad. So we are the first one in the case definition is going to be an acute respiratory illness. So that will include having fever or history of fever, cough, shortness of breath, gastrointestinal symptom in terms of nausea or vomiting, and diarrhea. And then in addition to these symptoms, you're going to have an epidemiological criteria. So the epidemiological criteria has to be specific to 14 days prior to the symptom onset. So we're talking about history of travel to travel abroad in general, or travel to the high-risk endemic cities in the kingdom. So we're talking about the capital, Riyadh, the holy city of Mecca, Jeddah city, Medina city, and Qatif, and also recently added Al-Hafuf. So, or in addition to these symptoms, the previously mentioned symptoms, a physical contact with a confirmed case of COVID-19. The second criteria, it actually consists of a patient who is being admitted as a case of pneumonia. And we're talking about pneumonia, which is either community acquired, hospital acquired, or any pneumonia. And when we say pneumonia, we're talking about clinical pneumonia and or radiographic pneumonia. Or if the patient is presenting or admitted already in the ICU, and they are presenting or progressing into an unexplained severe respiratory illness, including the ARDS cases. So when we are dealing with cases with suspected COVID, the initial testing to confirm the diagnosis, in addition to the clinical criteria, is going to be a laboratory confirmation test. And so far, what we are dealing with is the swab from the nasopharyngeal area. And then the interpretation of that study is going to be done through the reverse transcriptase PCR. Also, this needs to be taken into consideration, the false positive and the false negative, and we'll probably come to that when we are talking about imaging and the rest of the clinical presentation. So, so far, the COVID-19, SARS-CoV-2, or the new coronavirus, it is a moving target. So we are not really, we don't have a full comprehensive knowledge about this disease. We're still learning about this. And it seems like every time you put a slide up there, the knowledge is changing. So we're talking about a majority of cases being mild cases, and then less than 15% is going to become severe cases, and then critically ill 5%, with a case fatality rate of 2.3 that we know of so far. Being an emergency physician and talking about myself and my colleague, and talking about the other stakeholders, we usually, by nature, we jump to see our critically ill patient. And in the past, our personal protective equipment were not that aggressive. However, with this disease that we don't know how aggressive it is, we are talking about taking good care of ourselves, doing no harms, including ourselves. So putting an N95 respirator, the powered air purifying respirator, the eye shield, the gown, the gloves, all these things needs to be taken into consideration. Patient should be isolated as soon as possible into a negative pressure room. Then here it comes an extension of our history and physical examination, which is the point of care ultrasound. And we're talking about POCUS, as we call it, POCUS. It is an extension to our physical examination. So at this point, we are in POCUS in general, we are using it for diagnosis, guide management, do procedures, and then rule out complication. So when we're talking about using ultrasound, we have in general three major or well-known probes. We have the linear probe, the curvilinear, and the phased array. We use the linear probe by placing it, for example, at the vertical orientation. As we can see here, you can see that the lung is sliding between the two ribs here, and this confirmed that there is an interface between the lungs and the chest wall up here. And this is what we call the pleural line. So this is a rib, and that's why we are not seeing any ultrasound being penetrating through here. We are seeing the ultrasound being penetrating between the two lines right here. So once the ultrasound actually hit the pleural line, the alveoli is there. So the alveoli are gonna distract the ultrasound beam because it's not gonna be friendly, if that's an appropriate term to call it. So the ultrasound beam is gonna get distracted all over the place. Let's talk about the artifacts. The artifacts are going to be helpful to us. Actually, we want the machine to have the artifacts so we can see the following artifacts. We're talking about A lines, for example. So the A lines are a reverberation artifact that projects from the ultrasound beam hitting the pleural line. When it hits the pleural line right here, part of the ultrasound beam actually going to penetrate through and part of it is going to reflect back. And when that happens, another line is going to be drawn just parallel to that pleural line, and then that keeps on going, and then we end up with having multiple parallel lines that looks like we have multiple pleural lines, but this is just a reverberation artifact. And the presence of A line indicates normal aerated lungs and normal aerated lungs, asthma, or COPD. Moving on to the artifacts, so we're talking about B lines. B lines are laser-like projections of artifacts that you can see moving across the whole screen. You set your screen to a deeper depth, and then you can actually see multiple, one or two or multiple B lines extending from the pleural line all the way down. And the significance of the B lines is the presence of interstitial thickening, fluid or fibrosis, or the presence of fluid in the alveoli. The B lines can range from being 1 B lines, which is okay, 2 maximum, and then when it reaches 3, then 3 in each interspace is gonna count as abnormal or clinically significant. And then these ultrasound beam are going to be becoming more and more, and they coalesce, and then they give you the severe form, or the more you have B lines, the more the fluid or the interstitial finding are going to be seen on that interspace. So we're going to be moving from being negative, so no B lines, to mild, which is at least 3 B lines, to moderate, and then to severe, and moving from negative to mild to moderate, and then all the way to severe. So, and how do you get the B lines? You can either use the curvilinear probe by placing it over the chest wall of the patient, wherever you are suspecting to see the findings of the B line or the alveolar fluid or the interstitial fibrosis. And it also helps you with guiding management. So on the right side, on the left side of the screen, this is a patient that was seen initially, and then the appropriate treatment provided. So we can say that the patient has actually progressed from this situation to this situation right here. Moving on to the lung sliding. Lung sliding, as we said before, is going to be obtained by placing the ultrasound beam, the ultrasound probe across the patient anterior chest, for example, and then you can see each rib out here, and then you are seeing the lung sliding. The significance of that is to diagnose a pneumothorax. When you have a pneumothorax, you're not going to have a lung sliding in this area, for example, and it will look like this. So in the previous slide, we saw that the pleural line was moving back and forth. In this one, the patient is trying to take a deep breath, but it is that we don't see any lung sliding out here, which indicates absence of lung sliding, indicating the probability of having ultrasound, the probability of having pneumothorax. You can augment your study by using an M mode, and when you place the M mode and then activate it, the chest wall up here is shown down here, and it is grafted as a continuous line, as you can see on the top part of the grafted lines. Because there is lung movement down here, then you can actually see that it is grafted out as dotted line. And this, what we call it, the seashore sign, which is a good sign. That means there is a lung sliding, that there is no pneumothorax. Contrast to this one with a lung pneumothorax, The chest wall, again, up here, the top part, so it is grafted as continuous line. Here, there is no movement, so you can see that instead of that dotty line that looks like the sandy beach, it is also grafted as a continuous line. And this is called the barcode sign because of the continuity of the lines. And when we put both side by side, then you can actually appreciate that this is sandy beach, and this is a continuous line. And this is significant for pneumothorax. So another artifact, which is the comet tail, that you can see actually small artifacts that runs across the pleural line. You can actually appreciate this and call it that there is a movement at the interface between the lung and the chest wall at the pleural line. The sensitivity and specificity of the chest X-ray versus the ultrasound in a traumatic patient in this study showed that the sensitivity of the chest X-ray is of the ultrasound is better than a supine AP chest X-ray using ultrasound. So as we said, the loss of lung sliding can be a pneumothorax. However, this disruption can be pneumothorax, but it could be other finding, including atelectasis, mainstem bronchus, and mucus plug and pneumonectomy, and moving on with the pleural scarring from pleurodesis or inflammatory pleural disease and so forth. And it is not going to be helpful in a previously manipulated pleural disease. There is another phenomena that's called the lung point. As you can see here in this picture, you can actually see that on the right side of the screen, you can see that there is no lung sliding, but on the left side, coming from the left side under the rib that we can see on the left side of the screen, you can actually see that the lung is showing coming as a curtain, and then it moves away. So this is called the lung point. And the significance of the lung point is that it is very highly specific for pneumothorax. The sensitivity is not that great, but the specificity, once you see it, reaches 100%. The lung pulse, which is the perception of the pleural line with the heart pulsation, and this is this carries a good sensitivity and 100% specificity for atelectasis. The lung hepatization, in this image, as we can see here, this ultrasound probe is placed at the patient's right flank, and it is showing the diaphragm right here, and then the liver. And then the lung is not supposed to show, because as we said before, usually you are dealing with an aerated lungs, and it's going to reflect all the ultrasound beam up. Once you start seeing that the lung is looking like the liver, this is what we call it the hepatization of the liver, and then the consolidation is going to look a bit denser, and we're dealing with the lung as if it is a solid organ. And that's why you are actually visualizing almost everything. And you can see an air bronchogram here in the ultrasound clip. So we are talking about A lines, and then B lines, and then all the way to consolidation. What is POCUS going to help us in COVID-19? I will ask this question to Dr. Hussain Alhashem, and Dr. Hussain, take it from here.
Assalamu alaikum.
Walaikum assalam.
How are you, everybody? I'm very thrilled to be with you guys, very humbled to be with such a great panel. Thank you for Sassam. Thanks, Dr. Jamil and Dr. Rola, for the invitation. I'm going to talk a little bit about POCUS and COVID-19. Hopefully my talk is going to be mainly clinical, and then I am more than happy to discuss with my colleagues and with you and take as many questions as the time allows to. Let me start with sharing my screen. Is it, can you all see it? It's good? Excellent. COVID-19 imaging, specifically ultrasound application for this kind of disease. First of all, I do want to emphasize that COVID-19 is not primarily a lung disease. So it's a spectrum of diseases, spectrum of pathophysiologies, and maybe lung manifestation was the first manifestation that we picked up on and that we found in this particular disease. And as soon as we found out that this disease has a lot of lung manifestations, many people started to ask the question, could ultrasound be helpful in this disease? And I'm also picking up on what Dr. Ammar said. So conventionally, to do ultrasound for COVID-19, we're doing a typical ultrasound for a lung physiology. So we're going to follow our protocol. So what probe are we going to use for this study? Ideally, we use the linear probe to study especially the fine details of the superficial pleural line and lung consolidations. However, in such a disease where we can find a lot of pathophysiology, especially deep and in multiple lung zones, some people indicated that we can use the curvilinear probe, and that will help us a lot in identifying especially deep structures and if we have any consolidations or pathologies deep inside the lungs. So conventionally, and for those who don't do lung ultrasound briefly, we have to do 6 studies bilaterally for each patient. So in order to do a comprehensive examination, we have to tackle those 6 lung zones, number 1, 2 in the parasternal long plane, number 3, 4 in the axial plane, and number 5, 6 posterior in the posterior part of the brain. And that will allow us to have a comprehensive picture of what's going on in the lungs, especially in a disease that can present with pathologies or patches in multiple areas of the lung. So how can we apply this? And we're going to talk about clinical application at the end, but I want to talk specifically about 2 studies. They have been talked about a lot in the literature or in the podcast. First, allow me to say that this is a very new disease. Do we have conventional studies? Do we have randomized control studies? We don't have a lot of those, but we do have a significant number of emerging letters, emerging studies that are not randomized, not controlled, but they're talking about patients that they saw, especially in hot zones like China and Italy. So the first one is findings of ultrasound, findings of lung ultrasonography of novel coronavirus pneumonia during the 2019-2020 epidemic, and this came from China specifically. What they tackled in this study is what are we going to find specifically in doing ultrasound for those patients. What did they do? They did compare CT findings. If you remember, the Chinese hospitals or Chinese doctors, they used to do a lot of CT scans for those patients to identify this disease. So they compared the CT findings with the ultrasound findings for those patients. What they found is most of the findings concentrated within the pleura and the subpleural area. And that correlates with the pathophysiology of the disease. If we are talking about a proposed pathophysiology that goes mainly in the periphery, and mainly in patches in the beginning, so that makes a lot of sense. There's a lot of water fluid accumulation, a lot of scarring, a lot of tissue death in the peripheral of the lung zones, and that will cause some irregularities in the pleural line, and this will show in our ultrasound. Also in our B lines, usually we see few B lines in each image. We see up to 5 in a normal ultrasound image, but in those patients we see a significantly higher number of B lines, to a point where sometimes the entire screen or the entire pleural space is a B line. They call it a waterfall sign, where it's kind of like a waterfall. It's falling into the pleura. The other findings is that the significant finding is the lack of pleural effusion. In other disease physiologies or pathophysiologies, we see the accompaniment of, especially in bacterial pneumonia and CHF, we see the accompaniment of pleural effusion bilaterally. Here, we don't see that in COVID. The lack of pleural effusion is highly significant for a COVID-19 diagnosis. So in conclusion, focal B lines, multiple B lines, pleural thickening, and pleural irregularities, and sometimes they call it missteps or pleural discontinuation, that we can find in COVID-19 patients. Let's look at another study. It's called Preliminary Study on the Ultrasound Manifestation of Peripulmonary Lesions of Non-Critical Novel Coronavirus Pneumonias. And this is also coming from China. What they found, I will show you some pictures that they posted in this study. Those pictures are all coming from the study, which is open access, and you can access it online. Here are some pictures comparing CT scans of the ultrasound findings. Unfortunately, those are not videos, but I'll show you a couple of videos later on. So we see here there are this case coming with multiple patches, which specifically patch on the right side. What we see on the right image, which is the ultrasound image, if you can look at the pleural line, I don't know if my mouse is visible. If you look at the pleural line, you can see some discontinuation of the pleural line and some merging of the B lines, which makes it a very big B line. Let me see if I can annotate so I can show you. Okay. Yeah. So here, there is a discontinuation of the B line right here. And then this huge wide B line that is indicative of the merging of the B lines. All right, let's go next. All right, next picture. The same, we have a CT scan findings here on the left side, and we have an ultrasound finding on the right side. This ultrasound finding is a classic presentation of the waterfall signs. Here we have a merging B line that is almost entirely becoming a one B line, covering all the pictures, and that is indicative of COVID-19 presentation. Next one, you can see again, there's pleural irregularities, there are pleural discontinuation, and there is a B line that is huge in the middle. Again, and this is just to emphasize the area. Those pleural lines are not smooth at all. You can see some irregularities and some discontinuation in those lines. So what did they conclude with those? In this study, they had 20 patients, and they did a retrospective analysis. They correlated their ultrasound pictures, and they brought up these CT scans, and they wanted to understand what's going on with those patients and how can we find those findings in COVID-19 patients. What they found is 75% of all findings, of ultrasound findings, are present in the posterior and inferior part of the lungs. Yes, we can find some findings in the anterior part and the upper part of the lungs, but mostly, and here's your money, is going to be posteriorly and inferiorly. And that's what we found even in CT scan. I think this is a recurring theme. We found that those patients mainly are accumulating a lot of fluids. Those fluids are coming down, and they're accumulating down in the lungs. Now, there is a very interesting site that I recommend you to go to. It's called the POCUS Atlas. It's open access. It's done by amazing emergency medicine ultrasonographers. And one of those ultrasonographers, he documented one of his patients along the days, and he had multiple images and multiple ultrasound images. And I'm going to go through this with you. So let's look at the first picture. This is the first day of the presentation. We have good pleural lines. We have maybe few B lines. This patient is mildly symptomatic. He has some fever and some cough and maybe some hypoxia, but overall looking well. But this patient was admitted. By day 3, we can see, look at the difference here. Pleural line is very ragged. It's not smooth. There's some fluids underlying the pleura. This is not considered pleural effusion. This is just some fluids under the pleura. There are no B lines yet for this patient. Let's come up to day 5. Look at day 5. Day 5, look at those B lines here. There are a lot of B lines, and they are accumulating to becoming one B line. Coming to day 10, there's the same. There's a lot of B line, very thick pleural. The thickness of the pleura is very huge, and the smoothness of the pleura is gone. But now look at day 15. Day 15, this patient is becoming much better clinically. The fever is subsiding, patient is not intubated anymore, he's breathing normally, his oxygenation level is okay. His B lines are coming back to normal. They're not kind of like becoming a waterfall sign. The pleura is still ragged, and I believe that a lot of those patients will have a lot of pathology remaining after the recovery. But you can see that maybe we can utilize POCUS in reassessing those patients instead of CTing them or doing a lot of invasive studies for them. We'll look at more examples of pleural thickening. Look at this pleura. Pleura is very ugly. Pleura is very thick. It's irregular. There are no B lines in this picture. On the right side, I also have a very irregular pleura. Pleura is usually smoother than this. It usually is very smooth with few B lines. Now, here's an example of some consolidation. We've done B lines, we've done pleural thickening. Here's an example of some consolidations. And most consolidations found in those studies are found in the subpleural area. And if you can see here, I don't know if you can see my mouse, but there is some kind of small hepatization area with maybe air bronchiogram and air bronchulogram. That's what they call it or describe it in the studies. And that is very, very clinically indicative of COVID-19. Okay, finally, with the final examples, I have an example here to compare a COVID-19 patient with a CHF patient. As Dr. Amr said, a lot of those signs, B lines and pleural thickness, they can be found in CHF. So one of the things that we said is the lack of pleural effusion. That's one indication for COVID-19. The second one is, and look at this picture here, the pleura is very smooth with the CHF patient. The CHF patient is on the right. The pleura is very smooth. There are few B lines. On the left, the pleura is not as smooth as on the right. We have some discontinuation of the pleura, so that can give you a clue of what's going on underneath those pleura. All right. I'm finally going to talk about some, just not to make it long for you guys, I will talk a little bit about medical legal aspects and how can we use this ultrasound clinically. And I do want to discuss this more with my colleague. This is a final paper done by our Italian colleagues talking about their experiences in using lung ultrasound for COVID-19 patients. And I'm just going to mention their conclusion is that during this pandemic, in the COVID-19 pandemic, using ultrasound for them, and this is a quote here, they have noted a reduction in the use of chest x-rays and CT scans during this pandemic due to the help of point-of-care ultrasound. Now, this is very applicable. Is this clinically significant? Is it very scientific? No, but I think all what we have nowadays is anecdote, and I think we should take that and build on it and see what experiences do we have. I want to talk a little bit about how to use ultrasound in the COVID-19 era, and then how to use it clinically, and then I'll turn the mic to my colleague. This is one of the cards done by Denver Health. I think it's awesome. What they did is they have a clinical guidelines of how do you use ultrasound and how do you use the machine during the COVID-19 era. I think Dr. Amr emphasized on this, and it's please take care of yourselves first, take care of your patients, and wear your full PPE. Next, when using the ultrasound machine, I think there are a few main rules that you have to take care of, and then the rest, I think it's going to be super easy. So we have those big machines that we use in the emergency department, and we have the portable machines. I think the portable machines are not very prevalent, and we don't have a lot of those in Saudi Arabia. They have it more in the US and Europe. But talking about the big machines, I think the first rule is to keep your machine outside of your resuscitation area, especially if you're doing an aerosolization procedure. If you're doing intubation, if you're doing nebulization, if you're doing positive pressure, please take your ultrasound machine out. Prepare your ultrasound machine before coming into the room. So make sure it's working. So I want you to spend as little time as you can inside the patient room with the machine. So make it ready, put your MRN, put your name and everything, and make sure that you know how to use it efficiently. So you're going in, using it, and immediately going out. Some people use the sterilization technique, which is the same as a central line when you use the plastic bag and put the full-on cover for the probe, and I think that's great. But remember, once you're done, few things to remember: go out to your machines, take your PPE out, but keep your gloves and keep your mask and goggles. Clean the machine with a disinfectant that is certified to clean COVID-19. And there are some disinfectants, there are some resources that we can share later on. There's specific disinfectants that we can use to clean those machines that are certified to clean COVID-19 and other viruses. So wipe out the entire machine, wipe up the probe, wipe up the entire machine, the body, the keyboard, and everything. Once you're done, take your face mask, take your gloves, and use some other gloves to take the machine out. and put it in a clean area for at least 2, 3, 5 minutes before it's used again. Now, final notes is, how can we use ultrasound? How can we collect this knowledge and use it clinically, especially in the emergency department? Maybe my colleagues can emphasize on using it in the ICU, but for me as an emergency physician, I'm using the ultrasound for what patients? Who am I using the ultrasound on? And I think you can use the ultrasound for any of your patients, but there are some questions that has to be addressed. The first one is, can I diagnose COVID-19 with ultrasound? And the answer is no. Ultrasounds should be a tool that can help you to diagnose your patients. It can be a tool to elevate your clinical sense. We know that COVID is mainly a clinical presentation at this point, and we're going with clinical senses. So patients with fever, with shortness of breath, that maybe are a little hypoxic, but don't have any chest X-ray findings. What I can do is I can do the ultrasound maybe to reduce their exposure to CT. If I find anything with the ultrasound, that's it. This patient is coming in because they need to be monitored. That means they have significant lung pathology. If they don't have any ultrasound findings, maybe I can send them home and give them some precautions to come back. The other use of it is I can monitor their clinical progression. So if I have a good system in the hospital where I can save those images once the patient is coming in, I can do some images, my colleagues in the ICU can do some other images, and we can see how this patient's progressing by using the ultrasound, and that can significantly reduce the use of CT scan in those patients. And I think it will help us a lot in reducing CT scans. I've seen a huge surge in utilizing CTs, and that's going to make a huge effect in the future. This CT exposure is becoming a lot prevalent, with maybe on some patients that don't totally need it. So I think there is a clinical use of it. Can we diagnose with it? Can we rely on it for diagnosis? I think no, but I think it's a very, very important tool that we can put and utilize in the emergency department.
Thank you very much, Dr. Hussain. I myself actually learned a lot from your expertise. I think we should switch gear and move to the next topic, and then we can actually take questions and answers and answer them accordingly. So I already introduced our great colleague, Dr. Amr Ajlan, who is an associate professor and a consultant of radiology at King Abdulaziz University. We'll be talking about chest X-ray, CT scan finding, and what do you do if the chest X-ray is normal? What do you do if the chest X-ray is positive, however, the patient is not symptomatic, or at least don't have respiratory symptoms? Dr. Amr, take it away.
Assalamu alaikum. Thank you, everybody, for the invitation. I think you hear me clearly and you could see my screen, right?
Yes.
Okay. So basically, we're going to talk about the chest X-ray and ultrasound part. And what I intended to do is actually to make it simpler from an emergency physician perspective, and also for somebody who's facing the patient for the first time, whether you're an intern, a resident, or a general physician. Now, what I'll start with, I'll show you this first quiz. I have two quizzes. I'll give you 10 seconds to look at this. So both patients, they're different patients. They presented with cough, fever, and chills. Now, this is a different quiz. These are two different patients presenting also with fever, cough, and chills. Okay, let's dive in. So the outline of this lecture is basically talking about some of the confusing CT terminology, because that's one of the things that bothers our colleagues in the non-radiology departments. We're going to take a flashback look at some of the H1N1 and MERS imaging. And the reason we're going to do that is going to be revealed during the lecture, mainly given the huge similarity between these agents when they present imaging. We'll emphasize the chest X-ray findings. And basically what I intend to do here is to make this the most important part of the talk, because If we talk about CT scan, that would be nice, but I think what you guys face for the first time is actually the first chest X-ray the patient has. It's almost universal, that's what we do, despite what we read in the literature about CT and how beautiful it is, right? So this is what you face the first time in a practical situation. Throughout this talk, we're actually gonna highlight some practical points, and this is going to be done through several case examples with a bit of literature. Now let's start with the first point. When you talk about consolidation, what you're talking about is a white lung that obscures or hides the underlying lung markings, such as the image that you see above. If you talk about ground glass opacity, that's also a white lung, but it's a white lung that does not cover the underlying lung vessels and other markings, and that's ground glass opacity. Now, this is consolidation, this is ground glass. X-ray is the same thing. If you see something that we describe as a consolidation, that means that you're covering the underlying lung. If you see something that's white that does not obscure the lungs, that's ground glass opacity. Now, one thing to highlight is that this is what I call the emergency physician's enemy, right? Because consolidations are easy to see on a chest X-ray when you're at the ER. It's a busy day, you see lots of patients, but when it comes to ground glass, it's a fainter opacity. And here's where the X-ray could be either very difficult to read or could be mistakenly called normal. Now, another term that you might hear about when reading about the literature, I'm not gonna emphasize this so much, but you're gonna hear about this too much when you read about CT and COVID. It's called crazy paving. What you see here is the ground glass opacity that does not cover the underlying lung markings, but you also see these lines. They look geometric, smooth lines. So these are the interstitial septae, the septal thickening here. So if you see both ground glass opacity and septal thickening on a CT scan, that's what we call crazy paving. So let's get that out of the way. A little bit of history that I made up. I call this the made up history of the viruses. This is from my perspective when we look at these viruses, because in 2009 we had H1N1. In 2012 we had MERS, and now we're having COVID. The reason I'm mentioning those, although the first virus is not a coronavirus, is because these novel viruses, the new viruses, for some reason, they present in a very similar fashion. And I'm going to show you a few examples as we go along. So this is a paper that we wrote in 2011 when we first encountered H1N1. If you look at the CT scan, you'll see that you have bilateral patchy opacities. These are mostly ground glass. They're peripheral in location. They're more common in the lower lungs. And this is very similar to what Dr. Ammar and Dr. Hussain just described when they talked about the ultrasound, right? The abnormalities are more peripheral and are concentrated at the lower lungs. It reminds us of COVID, although this is H1N1, right? Now let's go to another paper in 2014. We published this about MERS, and it was actually an easy publication, to be honest, because it was almost a copy and paste of what we saw with H1N1. Ground glass opacities, peripheral in location, sometimes they're peribronchovascular in location, as you see with this yellow arrow. And then you have more concentration of the abnormalities at the lung bases to the extent that they become consolidations. And you see these lines, which we call the septal lines, which is also crazy paving pattern. Again, very reminiscent of COVID infection as we see it now. Now, this pattern that I described to you, to simplify it, it's a complex topic, but let's simplify this. If you have opacities that are bilateral, peribronchovascular and peripheral, and at the lower lungs, this is a pattern that we call organizing pneumonia on chest imaging. It's basically a non-specific inflammatory response. It does not mean much. The lung just reacts in a certain way and gives us that appearance. We know from our literature that you could have that as an idiopathic form, and you could have that as a secondary form. The secondary form is something that you could encounter with many etiologies. It could be due to viral infections, non-viral infections, drug reactions, transplant complications, and lots of other etiologies. But for some reason, these novel viruses, whether it's corona, MERS, COVID, or H1N1, when they attack the lung does not know how to react. I simplify that as saying that the lung gets surprised and it just gives us an organizing pneumonia pattern. And this is what we're seeing, and this is what people are talking about more now with all the COVID hype, but we knew about that from previous viral infections such as MERS. Now, that's not to say that you could not have normal X-rays. X-rays could be normal in any of these viruses. The other thing is they could be unifocal, they could be multifocal, they could be upper lungs, they could involve the lower lungs, they might be central in location or perihilar, they might be peripheral, and they may even be diffuse. Now, the most important pattern to remember despite all of that is that when you have an outbreak of one of those viruses, such as what we're having now with COVID, the most classic pattern is what we described just a bit, is bilateral, peripheral, lower lung ground glass opacities. This is the most suggestive pattern. It does not mean that if you see another pattern in a clinically suspected patient that you would not call it a COVID patient, but this makes the patient highly suspicious. Now, before we go to our COVID cases, let's go to the Jeddah outbreak that happened during the 2013-2014 period. And these are a few MERS cases. So before we go to COVID, I'll show you a bit of MERS. The first case is a patient who's a 37-year-old male patient. And just by looking at the X-ray, you already know what you're going to talk about, right? You have bilateral mixture of ground glass and consolidated opacities that are peripheral location. Again, a very similar pattern to organizing pneumonia pattern or what we saw with COVID. The same patient, a few days later, has more extensive opacities, as you see. Now let's go to case number 2. This is a 27-year-old female patient who was confirmed to have MERS. When she started, she had this patchy ground glass opacity, again, increased density that does not cover the underlying lung markings. The patient presented with non-respiratory symptoms. This is one of the very important points that might be highlighted to an emergency physician, right? When you're talking about either MERS or COVID, you're always thinking about cough, fever, and all respiratory symptoms. But however, a good portion of patients may present to you with no chest symptoms at all. They might present with diarrhea, nausea, vomiting, or others. And this is something that we saw with MERS, and it's highly spoken about now with COVID. Actually, in a small study we did, we had about 17% of our patients presenting initially with non-respiratory symptoms when it came to MERS outbreak. Another point to highlight is some patients might have false negative results. This patient, for example, had about 3 to 4 false negative samples. They were all nasopharyngeal swabs, but despite of that, they are negative. What we faced at that time is seeing classic X-ray features in patients who had 3 or 4 negative swabs. The 5th or 6th swab might come as positive. And this is also a very practical point that we're seeing now with COVID as well. Now let's go to case number 3. This is just to show you an example of where MERS or any other virus could present in a focal consolidation that might confuse you for your typical bacterial pneumonias. However, with many of those patients, if you wait for a few days, sometimes hours, many of those patients show you extreme significant deterioration in the imaging findings that are very rapidly progressive. So this was 3 days after. You could also see in this image, it's almost this classic pattern with a more severe form, bilateral, peripheral, lower lung opacities, predominantly those ground glass hazy opacities. So rapid changes is something to keep in mind. Now, I'm not going to talk much about MERS in the literature, that's not the point, but I'll just show you one of many publications. And what's interesting in those publications, when they're non-imaging journals or they're non-radiology related, the description becomes a little bit more generalized. But if you look at the details, and now you know what I'm talking about, you might have a focal consolidation, that's true. But look at the other examples in this paper. They're bilateral, lower lung, peripheral, also an organizing pneumonia pattern, very similar. This is MERS, this is not COVID, but very similar to what you're seeing with COVID these days. Now let's go back to COVID-19. What I'll do here is I'm gonna go over cases and emphasize the practical points that I want to reach the audience with a little bit of linkage to the literature. Here's a 53-year-old female patient, confirmed COVID case. She presented with dry cough, fever, and chills. If you look, you're going to see the classic pattern. I didn't give you lots of images, but it's almost the same story. Bilateral ground glass opacities, they're patchy, predominantly at the periphery and the lower lungs. And in this case, the patient also has a peribronchovascular opacity. Again, what we called as an organizing pneumonia pattern as a reaction to the infection. This is very typical. Let's go to the X-ray of the same patient. So this is day 1 of presentation. It's a tough X-ray. This is why I say ground glass opacity could be the enemy of the ER physician. If you're seeing this in a busy day, and if you're not thinking about COVID, such as what we're doing those days, this might pass as normal. But if you look very carefully, you might question on this patient very faint early ground glass opacities in the classic locations. Something maybe here, that's another one. So the high index of suspicion should be always there, especially during this outbreak. Now, the same patient, if you look at day 2 and day 3, it's exactly the same pattern, but what's happening, it's rapidly progressive. This rapid progression is not very typical of your classic bacterial or fungal pneumonias. This is something that we saw with H1N1, MERS, and COVID. These bilateral opacities, and they're actually worse on day 3. Again, this is what we're talking about, a typical pattern that we actually discussed during even ultrasound. So rapid changes and a typical pattern. Let's go to another case. This is a 27-year-old female patient, positive for COVID, cough and fever. If you look at the X-ray or the CT, basically, they're both normal. And this is a problem. People are talking about false negative PCR results. You could also talk about false negative chest X-rays. So chest X-ray, although extremely useful, even CT, very useful, but they're not without fault. You'd expect to have a proportion of your patients, depending on the prevalence of the disease and how symptomatic you're looking at, you could have a proportion of your patients having normal initial imaging. If I recall the numbers that we had with MERS during the outbreak, we had as high as about 40% initial negative X-rays, 40%. The numbers that we're getting now with COVID are all over the map, but we're getting numbers around 20%. And here's a study that might be of interest to you. So this is from multiple emergency departments in the States. They took a good number of patients, about more than 600 patients. And what they discovered is that about almost 60% of their cases had a normal initial chest X-ray. Not only that, when the X-ray was normal, about 42% of those cases were very mild or subtle. They give you this example, which looks like all the examples that we saw with COVID and MERS a while ago. And they also give you this example, which was considered a subtle example. If you look very carefully, you'll notice that airly, faint, tough to see ground glass opacity at the periphery. Now, let's go to another case. This is a 37-year-old male patient. He has flu symptoms. It's also a case that's confirmed for COVID. However, think about this as a scenario. Let's say you're looking at this case the first time at ER. It's very tough to call the abnormality. That's the first thing you see. Again, it comes back to how difficult seeing ground glass opacities is in practice. Number 2, the high index of suspicion. And this is the CT scan. It's done at the same day, maybe an hour after. You could see how more extensive the abnormality is. It's very clear on the CT scan, all these patchy ground glass opacities that were very difficult to see on an X-ray an hour ago. So it could be subtle. On the opposite, we talked about X-rays being normal in patients who are proven to have COVID. Now let's look at what's very striking about this COVID outbreak. The opposite is also true, which clouds the picture. You could have patients who are totally asymptomatic with extensive, not only mild, extensive lung changes. And this is one of the papers that caught my attention. This is the famous Diamond Princess cruise, which was stranded in sea because most of the people who were riding on the cruise had the infection. And initially when they studied them, they didn't study the whole count, but they took about 104 cases. Out of those, 73 were asymptomatic. So 73 were asymptomatic. 45 out of the asymptomatic patients, so half the asymptomatic patients or more, had chest CTs that look like this. This is a patient who's totally normal, has no symptoms at all. And this is the CT that you see. This would have some significance as we go to the next case. Here's a 23-year-old female patient, also proven to have COVID. The patient presented from you guys in the emergency department to us in radiology as a case of a query acute abdomen. The patient had nausea, vomiting, diarrhea, no chest symptoms at all. However, and this is a teaching point to my colleagues, either in radiology or whoever is going to review the CT after we read it, look at the lung windows at those cases. We always obtain a bit of lung when we do the abdomen, and although subtle, it is 100% there. There you see these very faint rounded ground glass opacities, almost peripheral location. I remember calling my ER colleague for this case and telling them that this could be a COVID case, and you could imagine how this created some anxiety in the department because nobody expected that patient in particular to be a COVID case, and the precautions were very low. So this is a very important teaching point, and we're discovering more and more of those cases where the X-ray even on this patient, even after the CT, did not look impressive. It's a very tough call. Here's an example of a paper from AJR where you have multiple patients. These are all abdominal patients. They did not have a single chest presentation. And all of them had these opacities that are classic at the lower lungs and at the periphery, consistent with COVID. Now, a question is, how often should we use X-rays or CTs? Very tough. And I go back to what Dr. Hussain said, is that the science is still building up, right? And we have lots of contradicting evidence. However, I'll show you the ACR, American College of Radiology recommendations. They say, and it makes sense, that you need to be familiarized with the classic and less typical patterns of COVID. That's a no-brainer. You need to know how it looks like. They also talk about imaging, whether it's a chest X-ray or a CT, being not used as a screening or a diagnostic test. And I agree, it should be a clinical diagnosis. CT is a very hot topic. People are claiming that CT should be used as a first screening test in COVID hot areas, and that's a bit of a tough call. The ACR tends to say that if you're going to do a CT scan, don't do it on all patients, reserve those for special situations, meaning a patient who has a severe infection or a complication, or if it's a bit of a problematic, inconclusive case. Now, what they also talk about, and I like that point, is they talk about now being a season for the influenza, H1N1, MERS, and others. And that's exactly what I'm trying to convey here. They tell the physicians that, please, you're going to see lots of cases that are not COVID, that they look exactly the same as COVID. And I showed you H1N1 and MERS for an example. Now, why is CT a hot topic? It's because of all of the Chinese data, especially at the beginning. This does not mean that the ACR is right and the Chinese data is wrong. It just means that you have different scenarios and situations. So for example, in an area where you have prevalence of the disease being very high, that's more than your capability of doing PCR testing, CT or X-ray might be a good option to quick screen those patients. But in an area where you have a different protocol, and that's what the North Americans had. They had lots of testing, it was available, it was quick, it was accurate, so the need for CT was not as much. Now, what do we take home from this presentation? First is, the first chest X-ray may be normal or near normal in cases of COVID. 2, COVID and others may present as asymptomatic or non-respiratory symptoms, so keep that in mind for isolation purposes. Lung changes may be very quick and rapid, in a matter of hours or days. The classic appearance is a bilateral basiloperipheral opacity, more commonly ground glass opacities, and that's highly suggestive, especially if you see it now. What we call this is an organizing pneumonia pattern on the CT. Is just a non-specific lung reaction that has a very peculiar appearance. And remember, especially here in Saudi and the Middle East, we still have quite a bit of MERS circulating. So remember that MERS, H1N1, and other infections would look exactly like COVID. Quick practical tips. As an ER physician, what I want to know here is I need to be very aware of the hidden areas. When it comes to COVID, the hidden areas we're talking about are the bilateral peripheral lung bases, and maybe the area surrounding the hilum. This is what we call the central or the peribronchovascular regions, because if you have these together or alone, you're thinking about a organizing pneumonia reaction. And at this time, this is COVID till proven otherwise. Quick example, this could be viral pneumonia, could be bacterial pneumonia, but if you look carefully, now you're looking at the hidden areas, you'll notice that you have ground glass opacities at the periphery, so this makes it more of a COVID than anything else. Also, this patient had some hazy appearance of the hyla, which is going with the peribronchovascular involvement. Here's another tough case. At first glance, you don't see much, but if you look very carefully, there are these very faint ground glass opacities in classic locations. So this is another case that is positive. Now, if we go back to quiz 1, that's why I showed you this. Quiz 1, the first case was a MERS case, and this is a COVID case. Both are normal. So remember, normal cases do exist when it comes to chest X-rays. Quiz number 2, if you were to describe case 1, you'd say bilateral peripheral lower lung opacities predominantly of ground glass, and this turns out to be COVID. If you describe case number 2, it's the same description, and this turned out to be, COVID. The first case was MERS. Practical implications. If the first chest X-ray is normal, there's a good reason to repeat because we know these changes become apparent in a quick fashion. They're rapid. They might not be seen in the first X-ray if they're faint ground glass opacities that turn out to more extensive ground glass opacities or consolidations. Number 2, if imaging is suggestive, here's where I think imaging is useful. If it's suggestive, a negative swab or other PCR test, I don't think would exclude the diagnosis, especially if the clinical suspicion is there. Point number 3, this is possibly very useful in asymptomatic patients or patients who have non-respiratory symptoms. And finally, please remember that MERS, COVID, H1N1, and others could look very similar. In particular, if I had to highlight 2, remember COVID and MERS together at this time. This all has application for isolating the patient if you're thinking about the imaging in this way. By that, I end my lecture and thank you for your attendance.
Thank you very much, Dr. Amr. That was very informative lecture, very relevant to our current pandemic. I think you hit multiple nails on the head. I think having a clinical gestalt, doing a good history, good physical examination, considering all the geographic, epidemiological risk is important, keeping a broad differential, including the endemic MERS-CoV that actually has even way higher mortality that we saw and experienced, unfortunately, in the past few years. In addition to actually considering that patients might present with something different than COVID. Unfortunately, what we are doing right now is every patient, I say unfortunately and fortunately, but every patient that we see in the emergency department, we are just asking about COVID and then everything else, just because we are learning about this disease. So keeping broad differential is important, and it is a moving target. So we're going to have to go with what you actually described as this is the classic presentation. This is what we are expecting. However, it can present as anything. It can be focal, multifocal, bilateral. It can be upper zone, lower zones. These are important things to just keep in mind. One of the things that I need just to point out that in 2017, the MERS-CoV guidelines from the Ministry of Health was talking about any pneumonia case, radiographic or clinical, needs to be swabbed for MERS. And then in 2018, it changed to severe pneumonia because for some reason they found out that it is the classic or the most common and the most significant presentation. So we are learning about this right now. I just want to answer a few. I want to pass along a few questions to both of you. One of the questions that actually showed up in the Q&A section was radiological findings. Do they correlate with the severity of illness?
Yeah, that's actually a good question. Now we could talk about that regarding the 2 entities that we described today, MERS and COVID. With MERS, there were several publications talking about the worst prognosis with more bilateral and extensive involvement. Actually, we did also a small study on that we're going to publish soon, where if you had a bilateral diffuse airspace opacity, whether ground glass or consolidation, on an X-ray, if you saw that during the course of the patient as a worse X-ray or as a final X-ray, the mortality rate increases by about 13 folds. So that's a significant association. What's interesting is that the same observations are seen now with COVID. I'll just give you one example because there are different scoring systems. So there's a scoring system on a CT scan where people divide the lung into different segments, and they give each segment a score from 0 to 2 depending on severity. Then they summarize these scores to a total of 40. So any patient who had a score of 40 or close to that actually did not do well. And those patients who had a very low score, let's say 10 or 15, they did way better. So we know now that the more extensive the lung involvement with airspace opacity, whether ground glass or consolidation, the more likely the prognosis is worse. However, it's very important to keep in mind is that we do face quite a number of patients where they suddenly have extensive ground glass opacities that comes quickly, and it also disappears quickly, and the patient does well from a clinical perspective. So it's not a rule to be generalized, but what we take from that is if you have a patient who has lots of opacities, be careful. Now, when it comes to COVID, and that's why I showed the Diamond Cruz paper, because that confuses people, right? Now you're having a paper that's talking about a CT score, and then you go to about those asymptomatic patients where 50% of them had extensive CT changes and they're totally asymptomatic and doing well. So we still don't know the entire science behind COVID, but what I would say is, let's be cautious. The more consolidations in ground glass, the more cautious you have to be in treating, isolating, and managing the patient.
Also, if you allow me to answer also, shukran, Dr. Amr. I think your answer was perfect. And I totally agree that lung consolidations may add to the clinical picture and will add some information to us, to those who are more vulnerable, but we're still really early on in the disease, COVID-19. So we don't have a lot of data confirming that does it really correlate or not. Specifically, as we pressed on, and I'm just adding a couple of points, as we pressed on that many of those patients will present with non-pulmonary symptoms. We have a lot of patients with GI symptoms, a lot of incidental findings in CT renal scans that we've done in our hospital. So you will see a lot of patients with non-pulmonary findings who have extensive disease as well. The other thing I was going to press on, there's a point that I forgot in the point of care ultrasound, and that's just a side note. Some people are now talking about finding decreased vascularization or decreased vascularity in the subpleural area, and that also could be another clue to screen for patients.
Okay, so one of the other questions, somebody asked about the utility of using MRI.
Let me ask more. Do they mean MRI for the chest or MRI for the brain? Because these are the hot topics nowadays for COVID. And I also saw another question, if you allow me. I also saw another question talking about brain changes with COVID, so we could combine those together quickly.
Sure.
Now, generally speaking, MRI is not a practical way to go about looking at the chest for many reasons. First of all, the availability, the expensive test. Add to that even from a clinical perspective, if you're looking at lungs on MRI, it's not as easy as looking at it on a chest X-ray or CT. So basically, MRI is not a friend of air or lung in general. I saw a paper last week talking about changes of COVID on MRI, where they actually saw those MRI changes in the lungs when they were doing the MRI for a different reason. So let's say a lumbar spine MRI or an abdominal MRI. You do see it, but it's not that practical. Do we see it? Yes. Is it a practical way? No. So that's for the lung part. However, what's very interesting, and this pertains to what Dr. Hussain just mentioned as well, think about COVID as a viral infection that could affect any organ. Many viruses could give you pneumonitis or pneumonia. They could also give you gastroenteritis. They could give you encephalitis, and etc. Right? And the papers that are coming out now is that when imaging patients who have mild to severe CNS symptoms with the MRI of the brain, many of those patients have significant changes. Mainly, they have abnormalities of the brain cortex or abnormalities of the deep white matter. And they also, if you give contrast, you're going to see abnormalities on enhancement. Very similar to what you do in your practice to exclude meningitis by sending the patient for either a CT or MRI with contrast. So I just answered that because I'm not sure if the MRI question was regarding the brain part or the chest part.
Okay, well, that's actually two birds with one stone. That's interesting. One of the other question people are asking about the portable ultrasound devices. I probably gonna have to answer this one. So I had a portable ultrasound device that when it first came out in 2015, and actually it is pretty handy, especially if you go into the room and you're using it, you're going to use it instead of your stethoscope. So it is pretty handy. In the Italian experience, they are actually taking their portable ultrasound devices, whether it's hooked up to your mobile device or it's hooked up to your tablet. And they are doing studies out there because they're not going to they're not going to be able to do even chest X-ray or CT scan. Now the ultrasound, the portable ultrasound devices are even we have a lot of variety and options that we can choose from. Butterfly, Clarius, Philips. Unfortunately, I don't have any financial ties with them, but they are affordable, and you can get one right out the door price, like around 10,000 riyal with a subscription for 2 years for the Butterfly device, and it is pretty handy. Okay, so
another point with the portable devices, and I see a couple of questions about POCUS. The first one is by Dr. Abdullah. What's the sensitivity and specificity of POCUS? Unfortunately, we don't know the sensitivity and specificity. All we have is a couple of retrospective studies that have very, very few patients that are 20 and 20, I think. We don't have a very large number of studies that contains a lot of patients, so we don't know the sensitivity of the disease. All we know is that it will definitely increase the sensitivity of your overall picture clinically, in addition to chest X-ray, lab findings, chest X-ray findings. It will add this sensitivity to your clinical findings, but we don't know for sure what's the number exactly. And in regards to the portable ultrasounds, a lot of people are recommending to cover those with special probe covers that you use for central lines and such. And if you are using your phone, please use another phone, buy a cheap phone or whatever, buy a Samsung, I don't know, and use it and leave it in the department. So it can remain, it can remain, if it's infected, it can remain in the department and you can disinfect it accordingly.
Okay. Well, we are way over our time. The discussion is amazing. I guess we need to actually get together again because of the moving time.
Amr, can you allow me to answer one more question? I'm sorry, I know we're over time, but there is a very, very good question that I found in the question panel. Yeah. One of the doctors asked, if the patient is going for a CT of something else, do you CT their chest? And I think that's very, very clinically relevant because, so in one hand, I don't want to CT a lot of patients. I really want to avoid doing CT scans of the chest for my patients. And so I will do my best not to do those CTs. But if my patient who is a COVID suspected patient is going to another study, for example, if I'm sending the patients to an abdominal study or a CT of the brain, I think, to be honest, my personal view is do the CT chest because first of all, you want to limit your exposure to your CT scans. Those CTs are going to be cleaned for at least an hour or two after their use. So if you are highly suspicious that your patient will have severe clinical findings, severe pulmonary findings, and I'm sure Dr. Ammar can add on this question, but I think if you are really highly suspicious and you're doing another study, just do the CT chest so you can decrease the utilization of your CT scanner, decrease the time of cleaning, and benefit other patients, to be honest. Dr. Ammar, can you add on it?
Yeah, so
Sorry, Dr. Ammar.
Yeah, it's not an easy question, and we don't have very clear, again, science regarding this, but the answer is, with any COVID patient, I saw a very interesting comment in the question. Somebody was saying, so basically, so it's COVID till proven otherwise. That's, I think, the way we should deal with patients for now, unfortunately. If the clinical suspicion from the story of the patient and the exam is very suspicious for COVID, it does not matter whether the X-ray or CT are normal or abnormal. And to be honest, it does not matter whether the first PCR test is negative or not, because we know all of those three could be negative at the start. And we know patients could have multiple of those, and yet they all turn out to be negative. So I like this comment of saying it's COVID till proven otherwise, especially if the clinical suspicion is high. Now, the opposite is useful. Now, if you do a patient where the suspicion for COVID is not clear or less suspicious, and you do an X-ray that shows you the typical pattern, this is where it's very useful. Now you have to actually shift your attention to making this patient a COVID till proven otherwise. It's also the same scenario if you're doing imaging for something else. For example, the case that I showed you here for the abdomen case, the patient who presented with total abdominal symptoms, and the ER physician was extremely surprised by me calling him and telling him about the lungs, to the extent that he did not want to write that in the report. But I had to insist, because this is where the scenario that we think it's useful. It's the opposite scenario. No clear answers for such questions yet, but this is my take on the how to approach those patients for now.
Well, excellent answers. I think we also had a really excellent audience with us today, with those two great speakers that we had. I have to, we're going to have to end this. I'm guessing, as we said before, we probably need to get together again to interact and give more updates and discuss things and learn from each other. Thank you very much. Thank you, Dr. Amr. Thank you, Dr. Hussain. Thank you to Dr. Jamil Abu Al-Ainain, the president of the Saudi Society and the Medical Education section. By this, we will end our discussion. Thank you very much.
Thank you very much.
Thank you all. My pleasure.
Thank you, everyone. Thanks for all the attendance. See you tomorrow, inshallah, in collaboration with the Critical Care Society, talking about ECMO and COVID-19 cases. Thanks, everyone.